Okay, so just tell me briefly what your background is, Michael.
Well, I'm a clinical and school psychologist by training, and I've been doing research on an approach called motivational interviewing for about the last 20 years at Yale University School of Medicine.
Okay, and what was the genesis of that? How did you get into it?
Well, I got into it because I work with some of the toughest addicted people in a really tough neighborhood of New York City in the South Bronx, and we were really left with very little in terms of resources and how to get these folks who desperately needed to change their lives but who were not listening to anything that made any logical or rational sense. And so my colleagues and I said, we have to change this conversation in some way, and logic is not going to do the trick for them. So we started looking for something else.
Was there a particular age range when you started of the people you were working with?
Well, they were adults on locked inpatient psychiatric and detox units. And these are some, the toughest of the tough clients. And no matter how we approached them, they kept saying, no, I'm fine, I can keep using, leave me alone. Okay. When we came across motivational interviewing, it kind of turned the logical, rational approach to convincing people to change on its head completely. And instead of telling people that they had to change, that they desperately had to change, motivational interviewing taught my colleagues and I that we told them, look, it's up to you. You don't have to change. And boy, did that turn some heads in the hospital.
And motivational interviewing came from where?
So Doctors William Miller and Stephen Rolnick developed it in the early 80s. And since then, there have been a number of adaptations. Mine turned into motivational coaching, or my instant influence approach, as I talk about in my book. And we've boiled it down to its essence. How to get somebody who's resistant to change in a few moments to start talking in terms of change, in terms of wanting to change.
So it occurs to me, if you could give me a couple of examples
Sure.
of how that works, that's helpful.
Sure. Well, the first thing you want to say to somebody who's resistant, let's say somebody who needs desperately to lose some weight because they're clinically obese, they want to have gastric bypass surgery. I'm thinking about somebody who I saw in my health behavior change clinic. And the person is just not following anything that the doctors and nurses are telling him he needs to do. So the first thing we do with that person is we say, look, you don't absolutely have to change. And it's not just lip service. He doesn't absolutely have to change. And because I convince that person that I really believe that, he starts to open up. The resistance that is there in many people who don't want to change or who feel they can't is built up because many years of people have been telling them, you have to change, you got to do this, all with the best intentions, but it puts layer upon layer of resistance. As soon as you convince somebody that it's up to them, that they are autonomous in their decision making, then things begin to open. So that's the first step of my motivational coaching approach.
So the autonomy is crucial.
Absolutely.
And what I'm hearing, and just tell me whether I'm getting this right, is you have to build, as any coach does, a trust relationship, a rapport relationship, in order to get that point across.
Right. Absolutely. And in addition to that, to allow the client to tell you things that he thinks you don't want to hear. Because I think for a while clients will tell us things in very sophisticated ways and not always so conscious what we want to hear. But I give my clients all that permission to say autonomously whatever they're really feeling. And this one patient in particular said, look, I've changed so much, I've lost so much weight, I'm this close to the surgery, why is everybody on my back? And I said, I think from their perspective, they're on your back because you have 11 more pounds to go. And then you can have the surgery. You've worked on this for 18 months. And everyone was asking him, why stop now? Why can't you lose those last 11 pounds? Why do you seem to have given up? Those questions make logical, rational sense, but what motivational interviewing taught us and what my motivational coaching approach now does is it says scrap those questions. They only help the client rehearse negativity, excuses, even legitimate reasons. Even talking about legitimate reasons why he can't change is not going to help him change.
In essence, what it's doing, again, if I'm understanding, is it's keeping the resistance seated firmly.
Yeah.
It's keeping it in place rather than moving it.
Then moving it or bypassing it. So the first step of my motivational coaching approach is to reinforce autonomy and take as much time as you need there to convince the person that you really believe that the ball's in their court. But the second step is to ask a series of motivational questions that at first sound illogical. And instead of asking, for example, why can't you change, the first and most important question of my approach is, why might you change? What would make you decide to change? If you were to change, why would that be good? And that turns the conversation around, but it's so surprising to clients because they've only heard the opposite that sometimes they continue to answer the old question, why can't you? So with this fellow, I said, but why might you lose those 11 pounds? He goes, it's too hard. I've been working so hard. I need a break. I said, wait a second. I said, if you were to do it, and that's up to you, but if you were to do it, what would be your reasons? And that started a very different conversation.
Can you give me an example with an addict?
Yeah,
I mean,
sure.
you talked about the people in the South Bronx. You talked about that. Can you give me an example?
Sure. I can think of somebody that I worked with long and hard to challenge her addiction to opiates. And finally, she entered into a good phase of recovery, and for 6 months hadn't used any Percocet, OxyContin, or heroin. Was doing great, had a job, was going back to school. But one rainy day, I remember this so clearly, she calls me up, and it's a Friday afternoon. My thoughts are already on home and my family, and she says, you know what? I was thinking I can be a recreational user now. I mean, I feel the chills today, all through my body. And everything in me, as a psychologist, as someone who knows how this works, everything in me wanted to say, no, you can't. Autonomy out the window. Why are you thinking like that? The wrong question. She would have just told me all the things that would defend that. So I mustered all the strength I had in me, and I said, well, why did you decide to call me? Let's start there. And even though it's not why might you keep up your abstinence, it's a positive why question. I call them positive why questions, not why are you thinking about doing this disastrous thing? I said, but why did you do something positive? And the thing that she was doing that was positive was calling me. So I find the kernel of motivation and say, why do you have that kernel of motivation? And to her, I said, why did you call me? And it really stopped her in her tracks. She said, I thought you were going to say, no, don't do that, you can't. And I said, well, maybe there was a part of you that wanted me to say that. And she says, yeah, but the other part wants to use. So again, I avoided the use part. And I said, but why is there that other part? Why did you call me? And I think that's what's very hard for clinicians, coaches, and families with addicted people, is when they're headed towards relapse, or worse yet, when they've had a relapse, we always ask them the wrong questions. Why did that happen? Instead of, why are you now talking to me?
So what I'm hearing is that this is a very powerful, but quite simple, elegantly simple, really, way of redirecting. And in some ways surprising the client.
Yes.
By going in a different direction, but also taking them in a different direction.
But think about it. What happens when we're surprised? If somebody threw you a surprise birthday party next month, right? And you walk into a room and you didn't know, you were really surprised, our defenses go down. We're more open. And we pay more attention, frankly. So that's one element that you're right.
What other settings have you found this to be useful in? I mean, I can see very broad possibilities.
So I started with inpatient addicted people and people with severe mental health problems, but then moved into outpatient addiction clinics and then into emergency room settings. And that's what really taught me how to boil this down into, you can do this in about 7 minutes or less. And thousands of patients that we've seen in the emergency room have gotten this on smoking cessation, reduction of alcohol, domestic violence issues, taking their medication, weight loss issues, following up on referrals. We use the same basic questions, and because it's so surprising, and because it bypasses all the excuses, we can very quickly get to the heart of change, which in this approach is getting a client to hear themselves say why they want to change. Not my reasons, theirs.
What kind of research are you doing, and how are you validating all of this?
Sure. Well, we have adapted these questions as part of a very brief intervention for opiate-dependent people who come to the emergency room. and to get them to treatment. For problem drinkers, so non-dependent, non-alcoholic heavy drinkers come to the ER, as well as those who smoke and want to quit smoking. So the same core set of questions are in each of those research projects, and we're finding that compared to the standard, here's some information, or you need to do this, hey, you got to quit smoking, that this works far and away better, and it's remarkable in its effects. We found nearly 50% reductions in heavy drinking from a 7-minute intervention with people in the emergency room.
And is there a form for follow-up?
Yeah, we follow up with calls. They sometimes have to come back to the emergency room. They come in with families who give collateral reports of their reduced drinking or quitting smoking. We follow up with treatment agencies where they go to validate that they've actually gone and stopped.
It occurs to me, I mean, I'm looking at it through my executive coach eyes. It occurs to me that the approach would work in basically any situation. You could take it to an executive, you could take it
Absolutely. So along the way, I've gone from the emergency room to the boardroom because almost everyone that I've talked to about this, especially people in business, have said, wait a minute, it's scientifically validated, it takes a few minutes, and you don't seem so shrinky, we could have you come in and do a talk for us. And so I've gotten a lot of work that way with derailed executives, addicted executives. But once they got better from their anger issues or their addiction, they said, well, look, help me motivate my team now with this. So that's how I got into the coaching world, in particular executive coaching.
And tell me a little bit about your book.
The book is called Instant Influence, How to Get Anyone to Do Anything Fast. It was published just in May. But yeah, so it sounds too good to be true. How could that be possible? But what is remarkable about this approach is that anyone can do it, like you said. It's elegantly simple, and it takes this mindset shift from asking these negative why questions to the positive why questions. And really dramatic things can happen in a few moments.
Is there any training program to do this or anything like that?
There are. I mean, there's a network of motivational interviewing trainers, but I do quite a bit with the team. My business is called Motivational Management Associates, and we have a team of people who teach this motivational coaching and instant influence approach for businesses, organizations. We train anyone from physicians to probation officers, judges, executives, parents, and so people can look at my website, if I could.
So if our coaches wanted more information...
Yeah, www.michaelpantalon.com, or the book is available anywhere, Instant Influence.
And here at the conference.
Sure.
Yeah, one of the things that we're looking at this conference, and I think you've answered this, but let me just fine-tune, is whether there's a difference in the use of your model, if it's a medical setting or therapeutic setting as against another setting. And I think you're telling me that there isn't, but...
There's very little difference when you get into the 6-question, 7-minute approach of mine. There may be a difference as a prelude and an afterward, but while you're doing the motivating, it's the same 6 questions. But a physician also has the obligation, for example, to give factual feedback. A coach may do that as well. That's not necessarily part of motivating someone, because as we just heard Dr. Lehrer say, knowledge is not necessarily motivating. But a physician, a nurse has a charge, a psychologist even, to give that kind of feedback. An executive may want to give feedback to an underperformer. But once he or she has done that, and now they want to motivate them, we move to these questions, and they stay largely the same. I help people adapt them, so I coach people on the approach as well.
So there's 6 areas then, if I've heard. The first one is autonomy. The next is?
The next is 6 questions of 6 motivational questions. Why might you change? On a scale of 1 to 10, how ready are you to change? Somebody says, where 10 is totally ready and 1 is not at all. Somebody says a 3. The follow-up, which is the 3rd question, is why didn't you pick a lower number? Again, surprising, but it kind of corners somebody into saying why they have any desire to do this. After that, we say, imagine you were to make this change. You don't have to, but imagine you were. What would be the positive outcomes to you? Not your family, not the doctor, to you. And question 5 is a very important one, where we take the reason that the client gives us why they might want to change. And then we ask them, why is that reason important to you? And sometimes I ask that 3 or 4 times until we get to something critical. So for example, this patient in the health behavior change clinic who needed to lose those few pounds before he could have the gastric bypass surgery, I said, you know, you told me that your health is the most important thing here, but why is your health important to you? He says, because everybody wants their health, but why do you want your health? The second time I asked it, why is it important to you? So I can walk around, so I can live longer. I said, but why is it important for you to live longer in this healthier body? And only then did he finally say, because then I could visit my mother's grave. Because I swore to myself I wouldn't go until I achieved this goal. And that's what ultimately made him change, because he got to that final reason. The 6th question is, what's your next step? And it is their next step, if any. And that's the approach, all along reinforcing whatever the client says.
So you just, again, to my ears, given me an example of how a therapist could use this in any kind of a setting to step somebody towards what the crucial issue is.
I think everybody has somebody that they want to motivate, and we've all felt the failure of doing it in a logical, rational, or confrontational way, and I think anyone could profit from this.
Last question. Sure. What kinds of difficulties do you have trying to teach clinicians or coaches to use this approach? Where's the resistance? The resistance is around letting go of the questions that are the negative whys. Why can't you do this? What are the obstacles? Those are important questions, but they're for a later time point. When you're motivating someone, you're talking about their will, not the way to change. And those questions, what are the obstacles? Those are for when you get to the way or the method for change. So the basic idea here is very simple. Where there's a will, there's a way. Let's leave the obstacle and the way questions for later, and right now ask these sort of counterintuitive questions. Why aren't you less motivated? Is where I get a lot of resistance. People say, well, I can't ask that. That doesn't make sense. It's exactly because it doesn't make sense and it changes the conversation that it ends up working. Yeah. Anything else that's crucial to somebody's beginning understanding of this that I haven't asked you? Well, just the belief that we can motivate people. You know, we can influence, we're allowed to influence those around us, but this is a more positive psychology-oriented way, a more strength-based approach, and so keep believing that you can motivate someone in a moment and that it's possible. Cool. Thank you very much. Thank you.